Come on, it's just the two of us. Tell me the truth. And this was when there was a studied effort to run me out of town in Washington when I asked him this question. So I said, tell me the truth. Now, when they let you out and you were walking, didn't you hate them all over again? He said, yeah, briefly. I did. That's great when you're out of office. You can say whatever you want. He said, I did. But he said, I realized if I still hated them when I got in the car and drove out the gate, I would still be their prisoners. I wanted to be free, and so I let him go. And he said, wait. And he gave me that, and so should you look. But then I said to him, okay. But how did you get rid of the hatred? How? He said, well, I did it by focusing on the reasons I should hate them. I said, what do you mean? He said, well, look what they did to me. I was abused physically. I was abused psychologically. I didn't get to see my children grow up. I thought I was riddled with guilt for making a mess of being a father. In the end, it broke up my marriage. I had to sit helplessly in confinement while the people that I loved and had worked with were beaten and shot. He said it was awful. He said, I realized one day in a seething hatred, they could take everything from me. He said, except my mind and my heart. He said, now those things I would have to give away. I made the simple decision not to give them away. And then he looked at me and he said, and neither should you. And so you guys are in the possibility business. Have we made mistakes? Yes. Have we been disappointed? Of course. Are we better on some days than others? Yes. But you got to stay in that possibility business. In the end, all you've got that no one can take from you is your mind and your heart. Do not let the headlines, the madness, the craziness, short-sightedness, the rising tribalism. You know that everything that's unique about you is made more possible, not less, by believing that our common humanity is more important than our fascinating differences. You know that. So, however you can, to whatever extent you can, remind the people back home, wherever it is, that we can't walk away from this. There is no Brexit option that is not calamitous in dealing with HIV and AIDS. And when you get tired, think how tired Mandela must have been by year 11. And think how by hanging on, he lived to walk free, to live to be 95. And think if he would hear, he would remind you that there are no permanent victories or defeats in life. But there is a permanent attitude which will guarantee triumph or constant trial. So just suck it up and make something good happen. God bless you.
Looking back, over the last 30 years, even though sometimes we like to say we're quick out of the box, we're still way too slow. Because there's always this period where you say, please tell me this is not my responsibility. And that delay is lethal.
We thought that we might have as many as 50 cases in a town of 100,000. So to have 50 drug-resistant cases per 100,000 essentially is an outbreak. The medicines for MDR-TB were really expensive, anywhere from $20,000 to as high as $35,000. And so the World Health Organization actually had an official policy on MDR-TB. They said it was too expensive and that they didn't think that MDR-TB should be treated in poor countries. We went to the local authorities and said, look, there's a lot of patients with drug-resistant TB. We should start treating them. We're going to have a huge problem on our hands unless we get going right now. I have to tell you, when I saw Melquiades, I thought, oh my goodness, I would not be surprised if he died.
El tratamiento consistía de más de 11 medicamentos que se tomaban los pacientes al día. A ver, Melquiades.
No tengo ganas de tomar porque no me siento bien conmigo mismo.
Estas medicinas tienen efectos secundarios fuertes, pero son los únicos medicamentos que pueden ayudarte a eliminar el bacilo resistente.
Tengo 3 años con medicina y nada, 3 años.
Our patients went through hell in getting treated.
No, Melquiades, más que el tema de tomar los medicamentos, sí, es un problema de desesperanza, ¿no? ¿Qué pasa?
The stakes were so high and we pushed very, very hard. We knew that we had to have success with these patients or treating MDR in the rest of the world would be written off forever.
We have one more clip to play for you.
Fue una lucha en la que fue bien dura.
Wow.
Gracias al apoyo tanto de los doctores, tanto de personas que realmente estuvieron ahí, se puede decir que estoy aquí.
We almost let him die. To think we almost let him die just because we thought it was inconvenient for us.
Se puede decir que es caro, no, que involucra mucho tiempo, cuesta todo eso, no. Pero yo creo que lo vale, ya que más adelante se va a ver reflejado realmente en todas estas personas.
Ladies and gentlemen, please welcome to the stage the panelists for the special session, Seizing the Moment for TB, Current Challenges in TB Care and in TB and HIV Integration.
Well, thank you, everyone. It's while people come in and out, I'll just transition into the panel. We are now going to focus more specifically on the HIV-TB connections, the similarities in both the challenge that the healthcare delivery system has the unique aspects of the communities involved, and the critical role that both must play in working with governments to develop and strengthen the delivery system that focuses on both diseases. HIV, with the 1.3 million deaths a year, is matched with a 1.7 million deaths from tuberculosis, 10.4 million new infections annually. A little over 400,000 of the TB deaths are HIV positive people, and that overlap, as anybody in support of a medical delivery system knows, must be capable of recognizing, diagnosing, and treating both diseases in the same populations. In addition to that, our ability to use the platforms that have been built by HIV, the maternal and child health platforms, the family planning platforms, we must be smart enough to use the already existing medical infrastructure to add on services to this complement to expand to the needs of the patients that we are already responsible for and with. That shared responsibility as we move into an expanded platform to ensure that HIV and TB are diagnosed and treated, and as we move into the challenge that non-communicable diseases affords for that same population, we need to be vigilant, as President Clinton pointed out repeatedly, in not allowing any of the gains already achieved to recede in the HIV arena, in the TB arena, as we synergize with program convergence, and as we prepare ourselves as a collective shared responsibility to engage the NCDs and move to universal health coverage. I am proud to introduce you to three of our panelists today. Carol Kachinga is currently the Executive Director of the Community Initiative for Tuberculosis, HIV, AIDS, and Malaria, a patient-led organization based in Lusaka, Zambia. She's also a member of the Zambian Country Coordinating Mechanism, representing TB and malaria constituencies. In addition, she's founded and national coordinator of the Coalition of Zambian Women Living with HIV. Carol has had several international executive board positions and is also the president of the African Coalition on TB, ACT, ACT, and former chairperson of the Pan-African Positive Women's Coalition. As a TB and cancer survivor and a person living with HIV, Carol knows firsthand what is needed to help those who are literally fighting for their lives. She's been able to transform this personal experience into a political campaign to address TB and HIV, and has incorporated TB advocacy into her regional, national, and global activism. So, Carol.
Thank you, Eric. So I want to talk about a few points today, and I'll talk about 3 points that are close to my heart. As you heard from Eric, I'm a person who works directly with the communities and a person living with HIV and AIDS who's also a TB survivor. So I want to focus my talk today on TB treatment, prevention, and integration, speak a little bit around stigma, and also about the much needed domestic resource mobilization. So throughout the week, we have heard in different sessions, it has been said again and again that data tells us that there are people that are being missed. We have heard that 40% of the people with TB are being missed by the health system for TB diagnostic and treatment. And in 2016, only 39% of the estimated number of people living with HIV who had tuberculosis received treatment for both HIV and TB. The devastating fact is who we are missing. These are usually the vulnerable in society, the population, and these are the migrants, the young people, people living with HIV, and people who live in poverty. We have heard that there is data that tells us where these people are, and we have the treatment that can mean for them the difference between life and death. Sadly, we are still missing them just because we have not done enough to remove the barriers they face in accessing treatment. But even for those who are lucky to access diagnostic and access the treatment, you find that the burden of the financial burden falls on them. And by that, they end up losing a lot of money because then most of the burden goes to them and not in the system. So as Elena Baruna, I want to quote what Elena Baruna, a health economist who presented at the TB 2018 session. She said that even if the TB service is deemed to be free, 70% of what is supposed to be free, the treatment cost is covered by household, which drives families right over the edge into severe poverty. Now, when I come to the preventive therapy, we have IPT, which is known as a preventive therapy, which can save lives. And yet, most people attending this conference are not even aware of that. It is a simple drug that can help people living with HIV and AIDS not to develop a TB disease. And now there are short regimens for preventive therapy, which some of them last for 3 months. There are even some which now will be lasting for just a month. And hopefully a generic one, a version. So my question again is, why is it that there are very few people living with HIV who are accessing this particular service? We also have, we heard that there's a simple urine-based rapid TB diagnostic called LAMP, which is available, and it is a cheap and easy way to diagnose TB in a person with advanced AIDS. Yet most programs are not using it, and people living with HIV are mostly unaware of that. I'm talking about this here because this is the audience here mostly is of people living with HIV and AIDS, and in most cases we are not aware of what we have in the pipeline, what can save our lives as people living with HIV. We know that TB in a person living with HIV can be diagnosed rapidly using a gene expert, but most countries are still using microscope, which is totally unreliable. I've always been asked, which is the hardest part of getting TB while living with the HIV virus? And my answer has been integration of treatments. When I found out my HIV status in 2001 and that I had TB, it took me over 6 months of going back and forth to the health centers for me to be diagnosed. And at that time, I was a young widow. I had just lost my husband and I had 2 young children to feed. The emotional impact of that on me, and also the loss of finances, because I was just a businesswoman then. Instead of me staying in my little restaurant to work, I had to go to the hospital back and forth. That also fueled the stigma, because I'd have to close my shop to go to the health center to access my service. Once I found out that what I had was TB, and then also my HIV was confirmed, I now had to go to 2 different health centers. So I always say, it's not right for you to cut up one person. I'm Carol. You can't cut me up in half with one going to the HIV center, the other one going to the TB center. I had also, unfortunately, had Kaposi sarcoma, so the other part of me goes to the cancer clinic and all the other diseases that I had. So for me, if there was a way to have an integration of services, but also of the diagnostic equipment, if you could have an equipment that could diagnose, I go in and you're able to diagnose my HIV, diagnose my TB, and also my cancer. My cancer right now is in remission, but if I default on my treatment, then it will come up. So if there's an equipment that can help me diagnose that, that would be helpful. On top of treatment complications, because of stigma, thousands of people die every day from a disease that is preventable and curable. Without addressing the treatment gap, the world will not achieve the NTB goal. And without prioritizing the high-risk groups, we will not close the treatment gap. For that, WHO put the End TB strategy, which most of us are aware of. But like any other development goal, the most significant barrier to effective TB treatment is lack of resources. This is why the high-level meeting on TB in September for us is very important and vital in making these issues a real priority at the highest level. And in order to realize it, public systems are now reaching out to our governments with help of civil society and private sector must ensure availability of existing and new medications, and nutritional support for people taking the medications, full psychosocial support, particularly for people with drug-resistant TB, and accessibility to aids for clients suffering disability, such as deafness that is caused by the TB drugs. At national level, in countries with high TB burden, we need governments to increase their commitment with bigger budget allocations for health and specific allocations to national TB programs. At a global level, I would like to say it is important for donors to continue supporting civil society movement. People always say there was strong movement around the HIV movement than the TB movement. We are not funded well. If we are funded well, we will do much, much more work. So they should continue because the work we do is we support and we complement government efforts. I don't know why, I think we heard from what Eric Gooseby said, why when 10.4 million people who develop TB every year is not making us panic. That is over 4,000 of us people living with HIV dying every day. I say this at all AIDS conferences. I don't understand why we people living with HIV are not really coming to join the movement for TB to do more work around that. Because if we do not, the investment that's been put in us from the HIV sector will be lost. I've been on treatment for 17 years. I could have TB and within a week I would die. So the 17 years that has been invested in me is going to go away. This is a global health risk that should make our heads of state show up at the TB high-level meeting in September and commit to reaching everyone. Make civil societies fight for investment policies and donors back the efforts up to the increased resources. I'll end to say it was at the high-level meeting, the HIV high-level meeting in 2000, attended by panicked and angry HIV activists, mostly people living with HIV themselves, government officials, civil society representatives, researchers that helped shape a radical transformation in the global fight against AIDS. And that effort is nothing when almost half of the people living with HIV are dying of tuberculosis. I say, let's take the same commitment to the TB high-level meeting and work to close the gap in testing, treatment, and prevention, including reaching 40 million people with quality diagnosis treatment by end 2022. I thank you.
Thank you, Carol. That's really terrific. I was on the phone the other day with a group of organizers for the meeting. We were talking about a few of the logistics and specifics, including my introduction to Dr. Paul Farmer, when someone emphatically stated, who doesn't know who Paul Farmer is? So I'm going to make this short. For those of you who do not know or need a refresher, Paul, physician, anthropologist, chief strategist, and co-founder of Partners in Health, professor and chair of the Department of Global Health and Social Medicine at Harvard Medical School, and chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. He also serves as a UN Special Advisor to the Secretary General on community-based medicine and lessons from Haiti. Dr. Farmer has written extensively on health, human rights, and the consequences of social inequities. But this is his official bio. What it doesn't say is that Paul is an extraordinary humanitarian who has helped countless people in developing countries around the world, beginning in Haiti. But it is known, he is known as the man who could cure the world. To me, that sounds about right. A colleague, a friend, and a compatriot in arms for many, many years, Paul Farmer.
Thank you. We had a conference call, as one does. By the way, thank you. We had a conference call to discuss the conferences. I'm going to put these on because I don't need my notes. Last week, and there was a division of labor being worked out, and I said, well, I'd really like to talk about therapy and diagnosis. I mean, That's kind of my job. And there are new therapeutics available for the first time in 20 years. Available, I'll go back to that in a second, as Carol just mentioned. However, when I got here today, and I heard there was a clip from the movie Bending the Arc being shown, I said, well, which one was it? And I saw that it was Melquiades. And I just want, instead of to talk about Dilamidid, bedaquiline, urine dipsticks, just stop and say, well, what became of Melquiades? What's he doing now? And I happened to hear from him yesterday, and he is now working, this young man that you saw who had extensively drug-resistant disease and had been the recipient of multiple empiric courses of the wrong treatment, which was, by the way, at the time national, but also global policy. Not an accident, in other words. Not a problem of his culture. If it was a problem of culture, it was a problem of the culture of public health that set standards too low for other people. Well, Melquiades now, and I remember this sitting backstage during the last session, inspired to say this, Melquiades is now a full-time health activist. That's what he has been doing for the last couple of years. Some of you may have met him at tuberculosis meetings. And in order to become an activist, you have to be alive. And this is something we learned, I think, or at least I learned it in the 80s, Carol just mentioned it, is that we all have a great debt of gratitude to people who engaged in health activism not only on behalf of themselves but on behalf of other people. They were not socialized for scarcity for other people. Now this is the heart of the problem of tuberculosis. We can and should talk about new therapeutic regimens. I'd be glad to. I was supposed to make this 2 minutes, which I've already failed to do. We can talk about new diagnostics. We should. As Carol points out, in order to do this work, you need staff, you need stuff, you need space, and you need systems. Safe space, meaning places where you won't get tuberculosis when you follow the recommendations of your nurse or doctor. Meaning, show up for clinic, well, you'll be showing up to an unsafe space. But it's more important to remember that the biggest problem facing us, or the biggest problems, are structural around poverty, gender inequality, disregard for others for many reasons, and they are the fruit of an adoration and worship of a neoliberal order where everything is a commodity.